Hi, class. This is Dr. Weaver. I'm going to go ahead and create another voiceover on a couple of topics. Actually, it's about 4 topics actually that I will be making a voiceover on. One of them is breast, axillary, and regional lymphatics, and I'll talk to you about this in class, of course. And then, of course, there is the female genital urinary system. I actually had done the neurological system before these because I read the list, the order wrong. And so I guess my mind was so much on the neurological system, I kind of wanted to get to it. I went a bit ahead of myself. And basically what I'm trying to do is I'm trying to match what I'm teaching in class with what you guys are doing with EDAPT. And I think that'll make, hopefully that'll make EDAPT a lot easier to do. But yet we know how that is, especially since the information comes from different sources. Anyway, let's go ahead and get started. Oh, how did I do that? So the breast, axillary, and regional lymphatics, it has about 43 slides altogether. And so I think I'm going to start around, let's see, I'll probably start around, this is better to start around slide 21. Yeah, so I guess that'll work. So let me go ahead and start sharing my desktop. Excuse me, everyone. I'm going to start sharing. And hopefully you guys can see my presentation. I really didn't quite know where I would actually start, but I figure slide 21 is a pretty good place to begin this particular lecture. Quite a bit of it is like me directing you to certain pages because you'll be looking at, for example, how to ask appropriate questions and also what are the rationales, but you should always, again, know what the rationales are. All right. So for this one, so we're talking about subjective data type of questions. And this is more specific to patient-centered care. And so here we are more concerned about the patient doing self breast examinations. And what I want you to do, or I'm going to refer you to page 382 to 385. And these are again questions, and it does provide the rationales as well. All right, and so we are asking here, or rather, our teaching is essentially going to be basic, and this is obviously one of the biggest reasons why we need to kind of go back and learn that anatomy again, along with some physiology, but especially anatomy, because you guys are going to be the ones teaching our patients how to actually perform these self-tests, if you will. All right. Of course, we review the screening guidelines, recommendations based on age and patient history. And of course, the American Heart Association, American Cancer Association, rather, has provided some guidelines. Of course, we begin at the age of 40 to 44 as far as screening for mammograms, mammographies. Of course, now if someone actually has a pretty strong history, this may change. And this is something that I would inform a patient to speak with their healthcare provider about, to see if perhaps instead of 40 to 44, may want to start 30 to 35 with those types of patients. It's kind of like when you think about prostate examinations. Usually you start around 50 years of age, but with African Americans, because we have a greater risk factor for prostate cancer, we're usually informed to start around 45, maybe sometimes even 40, especially if you have a first degree relative. In other words, a father or a brother. All right. Um, Now, an annual mammography is from age 40, 45 to 54. And of course, you have the uh, biennial mammography over the age of 55, or continuation of an annual. So again, just um, take a look at the page numbers that I also provided for you. Excuse me, just a moment. Apologies, I had to blow my nose. Um, all right. Now, these are some subjective data questions about the axilla, because all that will be a part of your assessment. This information is also on page 382 to 385, and the relevant questions and rationale. As far as the axilla is concerned, we look for tenderness, lump, or swelling. As far as appearance, if there's any tenderness or lump under the arm, or that's the question that we would ask the patient. Of course, we'll do an objective or physical exam, but these are just questions at this moment. As far as location, we want to ask the patient where and when did they first notice it. And as far as rashes, take a look at those questions. As far as appearance, any axillary rash, and you ask the patient to describe it. Any precipitating factors, for example, is it when a person puts on deodorant? Because deodorants obviously has chemicals in it that can cause a rash as well. So really important questions to ask. So I won't go through all of these. We actually provided these in the PowerPoint. Just get an idea, not expecting you to necessarily memorize this information, but at least go ahead and read it. And as I always tell you all, it has to make sense to you. And you'll see, the relevancy of the questions and what have you. So take a look at this one as far as what you would ask a pre-adolescent girl. Also, the pregnant woman. Uh, One of the important questions to ask is, are you planning to breastfeed your baby? That'll be really important here in this section. And also menopausal women. Um, and the relevant question, as you can see there. So again, take a look at the questions and the rationale on the page that I provided for you. All right. As far as the risk profile for breast cancer, it is the second major cause of death from cancer in women. But of course, early detection and better treatment modalities have increased survival. Um, let's see, risk, relative risk. So they also want you to review the factors associated with relative risk. And then your textbook, of course, on page 385. Just skim through that information, not anything. If there is something that you need to know for your exam, then I'll direct you to that area. But start with page 385 for questions and rationales as well. All right. Now, this information here, I won't actually read this per se to you because you can read this yourself. But as far as the objective data, what we just got done with the subjective, now we're looking at objective things that we can see or feel ourselves. All right, and check out what we do as far as preparation for the patient. So go ahead and read what that preparation will look like. Sometimes when we do give you guys, quizzes or exams and whatnot, it could be questions regarding how we prepare a patient for the examination. And let me say also, and of course I know I'll say this when we talk about the other slides in this presentation in class. As far as lab is concerned, we won't do a whole lot here. We'll probably mimic actually things like how are we preparing. In other words, we won't really do the physical examination per se in the lab, but more of the subjective data is what we'll be more interested in the lab for obvious reasons, right? And then, of course, look at the equipment that would be necessary. Take a note at the last bullet point pamphlet and teaching aids for breast self-examination would be important. Now, of course, this self-examination, breast examination, it does screen for breast masses or any kind of other abnormalities. We evaluate any presenting symptoms and also present an opportunity to teach the young women, all women, self-awareness as well as examination. All right. Now, of course, the breast examination, of course, it should be performed at the initial patient encounter in order to determine the patient's risk factor. Now, this examination is also warranted with high-risk women, those with breast pain or discharge from the nipple, or when a palpable mass is found by the patient. And of course, again, this is one of the reasons why we teach our patients about breast self-examinations, because oftentimes, especially when they're taking a shower, they're able to locate a mass initially and, of course, report it to the healthcare provider. All right, so inspection is one of the initial skills that we would employ, and this information can be found on page 386. I want you to take a look at what is normal, and also the abnormal findings you'll see in a kind of a table, right? And so here we're looking at the symmetry, the size and shape, and it is common for both breasts not to actually be exactly alike in size. So that is not necessarily considered an abnormality, a common or sometimes, a normal finding. That's what I'm saying. Take a look at the skin assessment, normal, smooth, or even color rather. Then also note any localized areas of redness, bulging, dimpling, also any skin lesions or focal vascular patterns. All right. And of course, let's see. So the third bullet point, a fine blue vascular network visible during pregnancy would also be normal in pregnancy. There's also a pale linear striae or stretch marks that follows pregnancy. And of course, edema, the absence of edema would be desirable. Right? And this is what I would say a perfect breast appearance, general breast appearance would look like. Be more or less normal. All right. And we continue with our inspection of the breast. We're looking at the lymphatic drainage of the nipple. And also we're checking for the breast skin for retraction. All right. And just take a look at that. You can find this information on page 386 to 387. And you will see the normal as well as abnormal findings. And so make sure you're reading both. All right. And just the information on this slide will be important for you to know as well. All right, since you obviously should know what normal looks like. And of course, when things are not normal or deviates from that norm, then we know that these are things that must be reported for further investigation. As far as inspecting and palpation of the axillae, take a look at page 388. All right. We examine the woman when she's actually sitting. We inspect the skin. We're looking for signs of a rash or an infection. We also lift the woman's arm and support it so that the muscles are loose and relaxed. Remember, if they're firm, then we may take that as a hard mass, and so we want the patient's muscle to be more relaxed, so you can get a more accurate assessment on the patient. We use the right hand to palpate the left axilla, and of course, vice versa for the right axilla. Reach the fingers high into the axilla and move them firmly down in 4 directions. And I believe your book actually have a nice example of that. Let me see if I can find that. It's kind of like an up and down kind of pattern and whatnot. I thought I brought that up already. Maybe I didn't. Well, maybe it's here. Let me see if I can show you guys a picture of the pattern that they're talking about. What does it say? 388. At least yeah, here it is. Well, at least I believe this is the one that they're referring to, that kind of up and down pattern. Let's see, where is it? Well, maybe I need to move it over here. Move this over here, and then I can share it. Let's see, view window, and it's 25. All right, so let me share this, show you what this looks like. All right, so you see this kind of a up and down pattern, right? And this is so that you don't miss anything, right? It's one of the reasons why we do like a vertical strip pattern, starting high in the axilla. We palpate down the mid-axillary line, just lateral to the breast, down to the bra line. All right, and then it talks about proceed medially in overlapping vertical lines ending at the sternal edge. This would be the sternal edge. So you're going from here and you'll end up here, making sure you're capturing everything. And take care to palpate every square inch of the breast and examine the tail of Spence high into the axilla. Reason for that is, and you'll learn this in class when I talk about it, the tail of Spence is the area where most cancers can be found. All right. Bring this back over here. And we'll share this again. All right, so I'm sharing this again with you all. All right, so as I said, that would be found on page 388. Also, we move the woman's arm through range of motion to increase surface area, that area you can reach. The lymph nodes are not palpable, although you may feel a small or soft non-tender node in the central group. And of course, if there's any enlarged or tender lymph nodes, that is something that we should make a note of and also report as an abnormal finding. Go ahead and share this again. All right, and this is pretty much what I was just talking about before. This information also can be found on page 389 to 390, palpation of the breast. And again, we do the vertical strip pattern. This is recommended in order to detect any breast mass and making sure that we're not missing an area. All right. And again, go ahead and take a look at the rest of this information. Here we talk about the two other patterns are in common use. There's one from the nipple palpating out to the periphery as if following spokes on a wheel. So you start with the nipple and then you kind of go in a circular motion away from the nipple. And also palpating in concentric circles out to the periphery is another one. All right. Now, in your nulliparous women, those who have never been pregnant, normal breast tissue feels firm, smooth, and also elastic. After pregnancy, of course, tissue feels softer and more looser. And then, of course, when a woman's is on her menstruation cycle, you have this premenstrual engorgement. And it is normal because of the fact that the patient has an increase in progesterone during that period of time. Right. Of course, with the this is what I was saying to you as far as lab is concerned. We likely won't be going through, these assessments, the objective findings, or the skills that are required, more so the subjective piece. Of course, if you guys feel you want to pull curtains and kind of want to go through some of these steps, then I wouldn't object to that either. I mean, you will have privacy, and of course, it would have to be two consenting students to do so. Let's see. And so continuing with palpation of the breast, take a look at the rest of this information here. We're essentially, as we're palpating the breast, and in particular, all four quadrants, we want to determine if there's any induration or subareolar mass present. All right. And check out how we would assess the nipple. It talks about with the thumb and also forefinger. and of course we're gently doing this. We depress the nipple tissue into the well behind the areola. Um, and so the tissue should move inward pretty apparently easily, right? Now, if the woman reports spontaneous nipple discharge, we press the areola inward with the index finger. Um, and we also repeat from a few different directions. And we're looking, of course, at the color and consistency of any discharge. And if that discharge is of the abnormal sort, then again, this is something that we should report to the team. All right. Now, if the patient mentions or she reports to you breast lump that she's discovered, with the self-examination, we want to examine the unaffected breast first to learn or to get a baseline from as far as the consistency of the breast for this woman. These are the type of questions that we could ask you, by the way, on a test. All right. For example, the question may want to know if a patient was to rather present to you with a breast lump, then we would it would want to know essentially, do you know the process? And of course, you would know by reading this that you look at the baseline first or the normal, and that way, when you assess the other breast, which is supposedly abnormal, then you'll be able to see that deviation. All right. And that information is on page 390, by the way. And then, of course, as far as a lump and a mass, we are looking at the location, size, shape, consistency, as well as if it moves. All right. Um, Now, as far as location, think about a clock. All right. So we would identify the location like we would do on a clock. So the nipple would be, well, whatever part of that clock that the hands extend from. That would pretty much be your nipple. But let's say if the arrow is pointing at like a 3 o'clock, right? Or the number three on the face of a clock. And of course, you would describe that, but also you would take a measuring tape and you can measure in centimeters, how far from the nipple it is located, the lump is located. So, but anyway, so these are important things to document when a lump or mass is noted. Take also a look at page 391 for that information. Some additional information to look at would be distinctiveness. In other words, is the lump solid? Is it by itself rather, or is it multiple? Take a look at the nipple. We want to know about the nipple. Is it displaced or retracted? Note the skin over the lump. Is it red? Is it dimpled or retracted? We're looking for tenderness as well as lymphadenopathy. Are the lymph nodes um, increased in size or enlarged and whatnot? So those are important pieces of information to document. Um, as far as teaching breast self-examination, take a look at these different methods here in this image. This information can also be found on page 392. All right. As far as teaching the breast self-examination, obviously we want to keep the teaching very simple because there's a lot of health illiteracy in our country. And, you can't be speaking way up here, when the patient is down here. You have to speak, in a language or in a way, in such a way, such as using what we call the teach back method. I teach you, and then you explain what I just said to you in your own words. That's what we call the teach back method. And so that's a good method to actually use. All right. So take a look at what we have here, ways to teach self-breast examination. that could also rather be found on page 392. Um, and of course, as you can see here, it says the simpler the plan, so we need to make it very simple. The more likely the person will adhere to the teaching. All right. Describe the correct technique and the reason and expected findings to uh, note as the woman inspect her own breast. And this is one of the reasons why I typically tell you guys to look at what is normal and then read the rationale. Um, Read also how things can deviate from that normal so that you're able to teach your patient what they need to know. Health promotion and maintenance is a huge part of NCLEX. All right, and also it's a huge part of your CMS. You'll be taking a series of CMS assessments while you're in the program, and we grade you on it. You are evaluated on that, and so knowing about let's say a disease process or any topic, when you know it well, and then we think about what parts of that knowledge needs to be taught to the patient. Always be thinking about that as you're reading through this material. Ask yourself, if I had to explain this to a patient or a family member, how would I do it? All right, so health promotion is extremely important. Teach the woman to do this in front of a mirror while she is disrobed to the waist. At home, when she takes a shower, where soap and water is used, it makes it easier to palpate for any lumps or masses and what have you. Then we also palpate, or then the palpation should be performed while the patient is lying in the supine position. Um, we encourage the woman to palpate her own breast while you monitor her technique. So you show her how to do it first, and then watch for a return demonstration. And then you take note of the deficits in knowledge, if you will, and that you continue to correct and make sure she's doing it correctly. Use a model for return demonstration as well as pamphlets. Um, um, can be helpful. And especially in a clinic, especially like a women's clinic, they'll probably have a model wherein you can do these types of things. And so just helps with the teaching. And then of course we have the male. Do not ever disregard men as far as breast examination is concerned, because even though it's about only 1% chance that a male can have breast cancer, still, what if someone is a part of that 1%? So keep that in mind. This you don't omit it, but it can be obviously abbreviated because the male doesn't have as much breast tissue beneath the nipple. This is a really important terminology here, gynecomastia, and this is basically has to do with hormones. That the ebbs and flows of hormone going up and down and whatnot in these young men. And this is basically benign growth of this breast tissue, and it makes it distinguishable from other tissue within the chest wall. It looks like the young man has breasts, especially around the areola area. All right, and this is something that we have to have knowledge of, because when we are taking care of the pediatric population, in particular adolescents, this can affect their body image, and so you have to be able to explain to them that it is normal and it will go away. Obviously, it can return, but we can assure them that it will go away. This tissue can also be pretty sore as well. When I was a teenager, I actually went through that myself, and I don't know if my mother knew what it was, because I was her first son, if you will, and it was very troubling to say the least. But obviously, being in healthcare and learning about it, This is the reason why we as healthcare providers, we need to be thinking that health promotion and maintenance, because we are doing quite a bit of teaching. All right. And if my mother, I guess, had been taught this by a healthcare member, then perhaps, my anxiety could have been allayed even more. And so anyway, take a look at the rest of this information. See here where it says reassure him that this change is normal, common, and also temporary. So very important. And we can test you on things like that. And also read page 393 for the rest of that information. All right. And then we turn to developmental competence regarding infants and children, as well as adolescent girls. Um, Now, as far as the neonate is concerned, the breasts may be enlarged and visible due to the mother's estrogen crossing the placenta, right? And it may even secrete witch's milk. And it is not a significant finding. It will resolve. And again, this is something that we have to educate the mother about. Um, we must note the position of the nipples on a preview prepubescent. That's what the way I normally say it. Child before adolescence, puberty. It's out the toy, but I'm trying to pronounce these words. Anyway, so um, and so it should be symmetric and also just lateral to the midclavicular line, and also between the fourth and fifth rib is where you should find the position of the nipples. They should be flat, and also the areola should be of a darker pigmented color. Right. Now, as far as adolescent girls, breast development usually begins on average between 8 and 10 years of age. You guys know this also is determined by race. Black girls, they tend to develop faster than white females. We also use the Tanner staging tool, and this also determines I can't remember exactly. The Tanner it has to do with puberty. Um, Let me see. I meant to take a look at that. I actually looked at it earlier, but I kind of forgot. But it's just a screening tool that we use. All right. Um, let's see. So yeah, it's a sexual maturity rating for girls. And it looks basically at breast development, right? It has five stages altogether. And so, for example, stage one would be the pre-adolescent, and it says there's only going to be a small elevated nipple, so that would be stage one. Stage two, you have breast bud stage. So a small mound of breast and nipple develops. The areola also widens more. And then, of course, stage three, the breast and areola enlarge. The nipple is flush with the breast surface here. And then there's a stage four, the areola and nipple form a secondary mound over the breast. And then, of course, the last stage, which is a mature breast, only the nipple protrudes. The areola is flush with the breast contour, and the areola may continue as a secondary mound in some normal women, so nothing to necessarily be concerned about. So that's pretty much the Tanner staging. It deals with the woman's breast, and there's actually five stages. And then, of course, there's teaching the breast self-examination, as we know as well. And for this age, that would be appropriate. Take a look at page 393 for that piece of information. All right. Now take a look at the breast changes that occurs in a pregnant woman. Vascular changes occur as a result of the hormones of pregnancy. All right, the nipples can be they can become darker, and the areola not only darken but become widened or more wide. Then, of course, with women when they're lactating, um, they produce colostrum. So colostrum changes to milk production roughly around the third postpartum day. All right. So breast engorgement will occur initially, and the nipples will become very sore for these mothers. This information can be found also on page 394 to 395. So this information can also be testable in terms of we want to know, do you know what happens during pregnancy, and when does colostrum change to milk production? And I'm saying this to you all because as you read through this material, be thinking about the type of questions you can be asked. It kind of sort of prepares you before you take an exam. When I used to study, I would always be thinking about how could they word this in a question? You know, how can they test me on this? And so I would be thinking about essentially the questions that could be asked. Right. Look at the aged woman. We're inspecting the breasts. They do look pendulous, flat and sagging. Unfortunately, as we get older, the body changes. Um, Changes noted on the breast tissue with aging is something we have to document. We are reinforcing the value of doing a self breast examination. Still very important because these women, they can develop breast cancer even as they age. Of course, as estrogen levels decrease more and more, it becomes a little less likely, right? It's kind of like when we talk about breast cancer risk. A young girl who has had their period much sooner in life is likely to have or develop breast cancer sooner, right? Because estrogen is one of those hormones that some breast cancers really feed off of. All right. Um, then, of course, it talks about women over 50 years old have increased risk for breast cancer. Um, right. Now, these are some of the abnormal findings as far as retraction and inflammation of the breast. Take a look at page 398, and I want you to look up those definitions of dimpling, or AKA nipple retraction. There's also edema, what we call peau d'orange, another important term for you to take a look at and understand. There's also fixation and deviation in nipple pointing. Um, Wanted to look at one of these as far as it's an interesting term, the peau d'orange. See if I can pull that up. Yeah, so it talks about normally no edema is present. I mentioned that edema exaggerates the hair follicles, giving a pig skin or orange peel appearance, right? Also called peau d'orange. Um, and so take a look at table 18.3. For as far as edema of the breast and what that would signify, and also signs of retraction and inflammation on page 398 as well. All right. All right. As far as breast lumps are concerned, I want you all to take a look at some of these terms: benign breast disease. Not all masses are malignant or cancerous. Take a look at the terms, the term cancer, also fibroadenoma, um, and also differentiating breast lumps. Look at the age, shape, consistency, the demarcation of where it more or less the borders, if you will, the number, mobility, and also tenderness of the lump, as well as skin retraction, pattern of growth, and risk of health. And that information you can find on page 398. Um, uh, let's see. I just wanted to look at one of these definitions. Yeah, so basically, um, information that we're looking for when we're differentiating breast lumps. Let me use cancer as an example. When it says, for example, likely age for cancer, you're looking at age 30 to 80 years. And of course, the risk increases after 50 years of age. As far as shape, it does look irregular and also star shaped. As far as consistency is concerned, it would be more firm to stony, hard. Demarcation, it will be poorly defined. I mean, there's like no clear margins or borders, if you will. All right. As far as number, it's typically more single, and mobility is more fixed. It's not mobile. You can't move it around. As far as tenderness is concerned, usually there would be none, but it can be tender. Again, we're talking about cancer. As far as skin retraction, it is usually present. The skin can be retracted. Um, and patterns of growth, it grows constantly. It gets larger. All right. And as far as a risk to health, it is serious, obviously, and it will require early intervention. And that's just dealing with, in terms of differentiating breast lumps. That is a fibroadenoma, benign breast disease, and cancer. And I just went over the cancer piece, but they have it in a nice table for you on page 398. One is juxtaposed against the other for comparison, and you can get an idea of what it looks like. For example, if we're looking at a benign breast disease versus benign breast disease and fibroadenoma, if we compare those two to cancer, cancer is firm and stony hard, whereas though um, benign breast disease would be firm to soft rubbery, and the fibroadenoma would be usually firm to rubbery. So the difference is one would be stony hard, whereas though the others would be more rubbery and can be soft. If it's a benign breast disease, all right. Not anything necessarily that you really have to know, but for an exam, if it is, of course, I'll let you know that as well. All right. Take a look at abnormal nipple discharge here. This information can be found on page 401. Look at mammary duct ectasia, intraductal papilloma carcinoma, which we know is cancer, and also Paget disease, intraductal carcinoma as well, or another form of cancer. So take a look at those definitions as well. Again, if there's anything that you need to know about that, and more specifically, I will place that on the focus sheet. Continuing with abnormal findings, disorders occurring during lactation. So while a woman is breastfeeding, they can develop mastitis. They can develop an abscess, a breast abscess, and also a plugged duct. Right. This is also found on page 401. As far as the male breast abnormalities, gynecomastia, I mentioned that has a lot to do with the hormones during puberty, and also male breast cancer, which I said is about 1%. But still significant, not something to ignore. Then, of course, we get to the summary checklist of breast and regional lymphatics. We're inspecting the breast as the woman sits, raises arms over the head, pushes hard on the hips, and leans forward. This is all a part of the assessment itself. These are things that we can pretty much do in the lab. Inspect the supraclavicular and also infraclavicular areas. Remember, when you think about the lymphatic system, it drains into the lymph nodes that are beneath the clavicle and also above the clavicle. And sometimes, and this is one of the reasons why it's so important when we are assessing the lymph nodes. Remember when we were assessing the lymph nodes in the lab, we were assessing above the clavicle, that's the supraclavicular, and then below the infraclavicular areas. And of course, if someone has cancer, it is possible that those are the lymph nodes that will be enlarged. And so whenever, I think I told you guys in class, whenever you find lymph nodes that are enlarged in those areas, there's a problem. There may be a problem. All right. Although I knew of a woman in Indiana when I was in school, hers was like constantly enlarged, but I don't think she had any issues. So I don't know. Nothing is complete or absolute, I suppose, but not too many things are absolute. Inspect, or rather palpate the axillary and regional lymph nodes. We talked about that and how that is performed. And also with the woman's supines, palpate the breast tissue, including the tail of Spence. Here again, that is the main area of cancer, of the nipples and the areola, and also teaching breast self-examination. So all important information and a good wrap up for this particular presentation. All right, so this one is pretty short. Yeah, this one's pretty short. I think it's only 43 slides. And so we went over, we started with slide 21. I'm going to go ahead and make sure I note that so we can stop here in the classroom. All right. All right. So whenever you see red, it means stop, or yeah, stop basically. All right. So that's about it. I'll go ahead and wrap this one up and get it loaded. And I'll actually, I think I need to start on the other one as well. Don't know if I'll do that tonight. It's already 1 o'clock. It's a time change. And of course, it'll be 2 o'clock here shortly because we're kind of jumping forward, if you will. Let me stop sharing this. I may just go ahead and get it over with, you know. Let's see. Yeah, so I'll be talking about the female genital urinary system as well. That has like 66 slides, and so hopefully we can get through that one fairly quickly as well. I don't know where I'm going to start though with that one. Anyway, thank you guys for listening, and I will talk to you soon.